Really excited to be here today and to share with everybody about what we're doing on campuses and kind of what public health looks like in the suicide prevention world. So I'm going to start off with a little bit of a story, and this is a classic public health parable, so some of you may be familiar with it. But two men were walking along a river, and as they were walking and talking, they heard somebody screaming from the river for help. So they jump into the river and they pull this guy out and drag him up to shore, tired. And as they're pulling him out, they hear another scream for help. As they jump back into the river and try and rescue this person or pulling them out, and then they hear another cry and another and another. And they keep jumping in and they're exhausted and they realize they can't keep up with this. They can't keep rescuing people who are drowning in the river. And finally, one guy eventually abandons the effort. He starts running upstream. And the other guy yells to him, "Where are you going? Why are you leaving all these people?" And he says, "I'm going to find out why they're all falling in the river." Because he realized we were never going to stop this problem of helping people in distress by rescuing them while they're drowning. That we have to go upstream and think about preventative approaches and see what's causing this. What are the factors that are leading to all these people falling in the river? And in this scenario, it might be a broken bridge. It might be a sign that fell down. It may be a capsized boat. We don't really know. But unless we go and deal with the causal factors or the risk factors upstream, we're never going to deal with this. And so when we think about this in the mental health world, we can kind of see how it applies. So there's a famous psychologist, Dr. George Albee, and this is a quote from him. And he said, "We're on a treadmill to nowhere if all our efforts are directed at helping individual victims. No mass disorder afflicting humankind has ever been eliminated or brought under control by treatment of affected individuals. Only successful efforts at primary prevention reduce the rate of distress in the future." We've certainly seen this with the pandemic. So COVID, if we only treat those who actively have COVID right now, we're never going to bring COVID under control. It's only through those preventative measures of social distancing and eventually mass vaccination that we're going to get COVID under control. And thankfully, we're seeing progress towards that. Unfortunately, in the mental health world and in suicide prevention in particular, we have taken a response of responding to those individuals who are in the middle of drowning, who are already actively involved in suicidal thoughts or making an attempt on their life and responding to them and trying to get them treatment. And we have to really move upstream and think about how can we prevent them from getting to that level of distress in the first place. So when I talk about suicide prevention with people, and I'll go over rates in a few minutes, a little bit of data, but you'll see that rates are rising generally. Over the past 20 years, they've risen quite a bit. And a lot of times I get asked, what are the causes? Why are so many people dying by suicide? And I tend to think about it a little bit like we think about car crashes. So if you were to ask me, why are so many people having car accidents or dying in car accidents? There's no one cause. It's different for everybody. So it can be the quality of their driver training. It can be distracted driving while texting. It can be driving under the influence. It can be situational factors like the weather. It can be the quality of the road construction and whether or not there's safety features on the road, like rumble strips and things. So there's many different causes. And unless we start addressing all of those different causes, or at least a good number of them, we'll never really make a good dent in the rates of death by car accidents. And so we have to kind of attack the problem from multiple perspectives. And so when we think about causes of suicide, we tend to talk more about risk factors. So what puts a person at risk for suicide? And I'm sure many of you could elicit some ideas for that. So loss of a loved one can be a risk factor. Financial problems, relationship difficulties are a big one. Isolation, substance use issues, any number of problems, financial difficulties. Mental illness is one risk factor. So we talk about risk factors and we want to kind of target those. So I did say we were going to talk a little bit about data, but I want to also acknowledge the limitations of our data. So suicide data in particular is especially hard to get. There's still a lot of stigma around it. And if you know anything about how deaths are determined in our country, it's not very well standardized. So we have coroners and medical examiners, and in a lot of jurisdictions, coroners don't have to have any specialized training, and they're declaring cause of death in situations. And so there's no standardized way of defining suicide. And a lot of coroners and medical examiners have a lot of hesitation about declaring something as a suicide unless there's very clear intent. So if it's ambiguous and they're not sure, so for example, an overdose, it often gets labeled as an accident or an undetermined cause of death. And so we may be underestimating significantly the number of deaths by suicide. So kind of keeping that in mind, I do want to share some data. And I put these pictures up here because somebody recently made the analogy of it's like looking at a painting rather than a photograph. So you get an idea of the broad strokes, you get an idea of the landscape, but all the details might not be exact. So I'm going to share the data with that in mind. Data also takes a while to get. So typically we don't get final numbers for about a year to a year and a half following the year that we're trying to calculate data for. So the 2019 numbers actually just came out. So in 2019, we had about 47,000 people die by suicide in the United States. That accounts for about 1 in every 60 deaths. It's the 10th leading cause of death in the country. Among 15 to 24-year-olds, so our youth and young adults, it's the second leading cause of death and accounts for about 1 out of every 5 deaths. So that means we're losing 16 youth a day in our country to suicide. As I already mentioned, we may be underestimating rates. And there's some researchers who've looked into this, and they estimate that it might be as much as by 30% that we're underestimating the rates of death by suicide. We've seen rates rising for the past 20 years. I think it's risen about 35%. However, in 2019, we did see a 2% decline. Now, we want to be cautious in how we interpret that. That could be a single year blip. But we're hopeful that maybe some of the public health approaches that we've been kind of doing over the past few years nationally are having an effect. And I will say that some preliminary numbers for 2020 have come out. So they still need to do all the data cleaning, but the preliminary numbers actually show that rates have either stayed the same or potentially even dropped. So some estimates are suggesting even about a 5% drop, which is amazing. And it is in contradiction to the national narrative, which has been COVID is contributing to this mass rise in suicide. Overall, we're not seeing that right now. There is a rise among African Americans, but the general population suggests that maybe we're not seeing a rise. However, one caveat is that we are seeing a huge rise in overdoses. And so again, unclear if the low suicide rates is actually kind of being compensated or a lot of those deaths are happening through overdoses. So just a little bit about the data. A few other things. 70% of those who die by suicide are not actively in mental health care when they die. So if we are trying to reach people at risk for suicide through individual mental health care, then we're not going to get most of those people who are at greatest risk. And then over half have no known mental illness. So there's been a tendency to kind of conflate the idea of mental illness and suicide. Lots of people who die by suicide don't have a mental illness. Some it's not been diagnosed, but for some, it's just an incredible number of life stressors all coming together at the wrong time and just not becoming overwhelmed and not being able to handle it. And so, again, we want to make sure we're reaching all people, not just kind of focusing on the mental health, the mental illness aspect of it. Males tend to die at 3 to 4 times the rate of females. However, females tend to attempt 3 times more than males. So the big difference there, the major cause for this is means used. So men tend to use more violent methods to attempt to end their life. So firearms, which are almost always lethal. Hanging is the second leading cause of death in our country by suicide. And women tend to use more cutting and substances, poisoning, overdosing. In the United States, firearms account for about 51% of deaths by suicide. That's in contrast to other countries where firearms are not so prevalent, tends not to be a leading cause of death. And then we know that suicide is inversely correlated with urbanization. So there are more deaths by suicide or higher rates of suicide in rural areas than there are in urban areas. Suicide also affects more than just those who die and their family members and loved ones. So certainly it has a huge impact on those individuals. However, if we look at kind of the full spectrum of suicidal thoughts and behaviors, we can see that it has a much bigger impact. So for every death by suicide, there are 25 attempts. So about 1.2 million people have attempted suicide in 2019. And then for 2019, we also saw that 15.4 million people reported having serious suicidal thoughts. So more than just a passing whim, they've seriously contemplated it. So kind of the point I want to make there is that it's not uncommon. I won't say it's common, but it's not uncommon to have suicidal thoughts. And only a small portion of those who have suicidal thoughts make an attempt. And only a small portion of those who attempt actually die by suicide. Most go on to resolve some of their life challenges and live lives that they enjoy and make meaning and whatever. And so it's really important for us to not freak out whenever someone kind of mentions suicidal thoughts, but to be able to have a conversation with them about that and recognize that most just need to talk. Most need some support. They're having a difficult time. That's the way it's manifesting themselves. And if we can have that conversation, that can actually help relieve some of that pressure, and they can move on to finding some ways to solve some of their challenges. Some data specific to college students. So the Healthy Mind Study is a national study run out of the University of Michigan that looks at mental health among college students. So first, they've been doing this measure within their study on flourishing, basically positive mental health. Feel like you're thriving. And so they've been running that since 2012. And you can see that rates are going down. So only about 38% of our students last year describe themselves as thriving. And I wouldn't say that's just a COVID effect. We can see it's been consistently declining. And then suicidal ideation has more than doubled in the past 13 years since they started the study in 2007. So more students experiencing more distress. Suicidal plans have nearly quadrupled, or I guess have quadrupled in the past 13 years. So more students are thinking about how they might end their life. And then the numbers are less clear on suicide attempts, but I think we can see somewhat of a rise in the number of suicide attempts across time. So to kind of just play that out on what that might look like on a college campus. So on a campus of 1,000 students, so a small college, you might see that 140 students have seriously considered suicide on that campus in a given year. 60 students have planned an attempt, and that campus might experience 14 students who make a suicide attempt in any given year. And that's a small campus. So then you take that up to a medium or a large size campus, and those numbers increase exponentially. However, being on a college campus is actually protective. So we know that, or rates suggest that college students die by suicide at about half the rate of same age peers. And so some of the reasons for that, that we hypothesize at least, is one big one is access to lethal means. So on college campuses, typically firearms are not allowed. And so when someone becomes suicidal, they don't have access to that very lethal method. Even though there's a lot of thoughts about college students and substance use, there are still some limitations on substance use on a college campus. And so they may not have access to some of those substances. And then there's community living. There's better access to mental health care on a college campus. And so those seem to be some of the factors that contribute to those lower rates. All right, so my office is the Campus Suicide Prevention Center of Virginia. Our mission is to reduce risk for suicide on college and university campuses across the Commonwealth. We serve 72 campuses, so all public and private nonprofit institutions in the state, both 2-year or 4-year schools. We're funded by the Virginia Department of Health and get support from them. And we're housed at James Madison University, but we really serve every campus in the state. So we take a public health approach to suicide. So that was part of the title of the presentation. So what does that mean? Public health approach means, first of all, we're data driven. So every intervention that we do, every program that we promote, we try to base it on what the research says. So particularly, what does the research say about what programs are going to decrease risk factors and what programs are going to increase protective factors? So access to good healthcare is a protective factor. Academic failure is a risk factor. We want to provide programs that help support students who might be struggling academically. We want to make sure students have access to good healthcare. So things to try and decrease risk factors, increase protective factors. Secondly, a public health approach means we involve multiple stakeholders from diverse disciplines and backgrounds. So sometimes when I contact a campus and I say that I'm from the Campus Suicide Prevention Center, they're like, you need to talk to our counseling center, and kind of push us towards the counseling center. And while we work extensively with counseling centers, we say, wait, we also want to talk to you, presidents, deans, academic officers, because every office has a role to play in suicide prevention. So from your financial aid office, financial aid officers work with students on dealing with their finances. Financial problems are a risk factor for suicide. They may be able to identify students who are at risk, so they have a role to play. Your registrar's office, most people don't think about them, but they can identify students who are academically at risk and help us find them and get them the supports that they need so they don't go down a really negative road where they fail and they feel like they're really struggling. Working with faculty and how they can integrate good mental health practices in their classroom, working with residents' life. Everyone has a role to play. And everyone has a role to play in creating a culture that supports emotional wellness. So we really try and change an institutional culture to where we're promoting positive health and positive well-being, not just preventing suicides. And then finally, a public health approach means that we incorporate many different strategies over time. So just like we're trying to address car accidents and deaths by car accident by safety measures in the car, seat belts and alerts, by rumble strips, by laws about speeding, by driver ed training, all those different approaches, we want to approach the problem of suicide from many different directions. So the CDC and the Suicide Prevention Resource Center, which is a leading organization in our country in kind of suicide prevention work, they've created this model that we've adapted for campuses. And they say that there has to be kind of 9 key elements or strategies that have to be implemented in order to do true, meaningful suicide prevention work. You can't just do one thing and say you're doing suicide prevention. It really takes a number of strategies to have a meaningful impact on the problem of suicide. And so we've adapted this for campuses, but you can think about how this applies to any community, any organization, any institution. So we're going to go through each of those. So the first one is identify and assist. We want to increase people's ability to identify those who are at risk and assist them to getting whatever support they need. That support may be counseling. It may be academic support and tutoring. It may be getting them into safe housing where they feel like they are safe. So a couple ways we do this, both on campuses and in the community, is doing screenings by healthcare providers. So we're trying to get more and more primary care providers and nurses and nurse practitioners to do basic screenings for suicide prevention. And we know from research this has a meaningful impact on reducing rates of suicide. So a lot of emergency rooms are just instituting this as part of their intake with every patient. But this is also important for college students. So college students are often struggling with anxiety and depression. It's like 30-40% are struggling with those things. And so asking them about those things, asking them about thoughts of suicide when they come into the student health center, making that a normal conversation with your healthcare provider is a way we can identify those at risk and assist them into getting support that they need. We also conduct a lot of what we call natural helper or gatekeeper trainings. We do a lot of these on campuses, but we also sometimes run these for the community, or other organizations run these for the community. These basically teach people to recognize the risk factors and warning signs for suicide, how to have a normal conversation with someone about that. Like, hey, I've noticed you're withdrawing a lot and you just seem more down lately. And sometimes when people do that, they're thinking about suicide. Is that something you're thinking about? And then if they find out that that is something they're struggling with, helping that person identify what resources they can take advantage of and access those. And so we do these trainings for faculty, for staff, for advisors, for student support workers, and even sometimes peers, so other students, to just kind of increase that net of safety. So more people, more eyes and ears paying attention and asking questions and having those conversations that are so important. Second factor is to increase help seeking. So again, 70% of those who die by suicide were not actively in mental health care. So they probably weren't seeking the support that they needed. at least a good chunk of those. And so how can we get more people to seek out the help that they need? We want to make sure they know the resources. And this is an issue on campuses. It's also an issue in our communities. I'd be curious if I asked all of you, which I'm not going to do for the sake of time, but if you needed mental health support right now, would you know who to call? Would you know where to go? Particularly if you're under-resourced, would you know how to access those? So we need to make sure we're promoting what resources are available. So promoting our counseling center, promoting other support services on campus, as well as promoting national resources. So the National Suicide Prevention Lifeline is an incredible resource. It's 1-800-273-TALK. I encourage everyone to put that number in your phone. I like to use the tagline, save a number, save a life. So just put that in. You can call them anytime, 24/7, and trained individuals will respond and help you navigate through a crisis. College students, we know, don't like to talk on the phone. So there is also the crisis text line. So you can text 741-741 and also talk to a crisis provider via text. It's also good for people who are in situations where it might be dangerous to have a conversation on the phone, an unsafe home environment, for example. Or for a college student who's in a room with a roommate and doesn't want their roommate to know what they're doing or what's going on with them, they can use the crisis text line. I also want to give a plug for the federal government has recognized the importance of these kinds of resources. And so they have approved for starting in July 2022, so a little over a year from now, we're going to have a 3-digit number, 988, that's going to route people to the National Suicide Prevention Lifeline. It's basically going to be our behavioral health, mental health equivalent of 911. So now when someone has a mental health crisis, they call 988 and resources will be sent to them. Emergency responders, if necessary, will be provided for them. Eventually, we're hoping to get mobile crisis teams in most locations, so people specifically trained to respond to mental health emergencies. So I'm really excited about the direction that we're going in that regard. We also know that students reach out to peers and talk to peers about their distress way more than they talk to faculty, staff, professionals. And so rather than fighting that, we can train students to be not mental health counselors, but kind of peer mentors, peer supports, basically informed friends who know how to listen, have good listening skills, are able to ask good questions, and are able to recognize when someone's in distress and when someone needs additional support beyond what they can provide. A lot of times, though, a student just needs somebody else who cares to listen and not try and fix everything, but just listen and be there. And so we train students to do that, to be peer supports. And then they can help route those students who need additional support into greater levels of care if needed. The third element is responding to crisis. So when a student is in the middle of a suicidal crisis or a mental health crisis, how do we respond to that? When they express that to their RA at 2 a.m. in the morning, who do we call? What's done with that student? Do they call the dean of students? They call campus security? Do they just take them to the hospital? We need protocols and policies and procedures in place so that everybody knows how to respond to that situation. Likewise, in our communities, we need protocols in place. So right now, when we call 911 because somebody's having a mental health emergency, we need trained officers or EMT providers to respond to that emergency and know how to respond in an appropriate way that can de-escalate the crisis, that can get the person to appropriate levels of care. And unfortunately, we've seen a lot of communities don't fully have that yet. We've seen examples where it goes poorly because we don't have good protocols in place and good training in place. We want everybody who could be responding to those crises to know how to do a basic suicide risk assessment and then how to determine, is this person just need to, have somebody talk to right now, or do they need to go to the hospital? How are we making that determination? Also, some guidelines for when to notify and involve parents. So college students are generally independent adults. And so they are under some protections where we aren't allowed to tell their parents things about them. However, in the case of an emergency where life is on the line, those protections are no longer in place, and we do have the right to kind of break FERPA, if you're familiar with that, to reach out to parents when it's helpful. But we need some guidelines for how to make that decision when it's kind of crossing the line. And some students feel like talking to their parents can actually make things worse. And so we need guidelines for who do we contact in those situations. The fourth one, reducing access to lethal means, is one that we have probably the best evidence for. So there's lots of research showing that if we can limit people's access to means that they might use in their life during those crisis periods, we can greatly reduce risk of suicide. So we know that for about 50% of people, when they make the decision to end their life, they act on that decision within 10 minutes or less. So that means they're going to reach for whatever means they most easily have access to. Now, some plan their attempt for days, weeks in advance, but a good chunk of them, potentially a majority, act on those suicidal impulses in the moment. And so if they have easy access to a firearm at their disposal, they're going to grab that and act on it. And we know a firearm is an incredibly lethal way to make an attempt. And so reducing their access to that means during those crisis periods can significantly reduce the chances. Same thing with medications. It tends to be a less lethal means, but if we can just make sure they don't have access to an excess amount of medications, especially like expired old medications or unnecessary substances to have in home, then we can reduce risk of dying. So on college campuses, the firearms thing is kind of easy in some ways because most college campuses don't allow firearms on campus. They might have a storage area with their campus security where if a student enjoys sport shooting or whatever, they can store their firearms there and go check them out to go engage in that recreational activity off campus, and then they check them back in. But limiting guns on campus reduces suicide rates. However, a lot of students live off campus. And so we have some great programs in Virginia that provide for free gun locks that can be put on guns to just kind of slow that down in case they have like a suicidal crisis. And so we also encourage people to normalize that conversation about access to lethal means. So if I know a friend is struggling, they're having a hard time, and I'm worried that they might consider suicide, I might say to them, hey, Joe, I recognize like you're having a really difficult time. You seem really stressed. And do you have access to a weapon? How about I take that and just hang on to it for a while, just until you get through this rough patch, just to keep you safe. Or if they don't want to give me the gun, how about I take the key to the safe where you store it, or the key to your gun lock, or even just your ammunition or a piece of that gun. So somehow kind of keeping it so they can't easily access that means in a crisis moment. I've heard some people say we want to normalize that conversation like we've normalized the drunk driving conversation. So 30 years ago, it might not have been seen as really acceptable to say to someone, hey, you've had too much to drink. Give me your keys. I'm going to drive you home, or I'm going to call a cab for you. But because of public health efforts and social marketing campaigns, that's now seen as completely normal and acceptable to say, nah, I'm going to give you a ride. I don't think you're able to drive right now. We need to normalize that lethal means conversation in the same way. We also encourage campuses to do what we call an environmental scan. So kind of looking around their campus and thinking about any place or situation that might be where someone decides to end their life or how someone decides to end their life. So paying attention, for example, to rooftop access. So if people don't need to access the roof, locking those doors, making sure students don't have easy access to them, making sure there's barriers up on high levels of parking garages, making sure that windows that are on higher levels don't open all the way. Maybe they just open a small crack. Making sure that chemicals are locked up. So only the facilities people that need access to certain chemicals, or the lab coordinators for your chemistry labs, that they have access to the chemicals, but otherwise students can't just walk in and access those. So kind of doing a scan and seeing how can we make our campus as safe as possible. So I'm going to stop again, and because there's a lot of strategies and it can get a little overwhelming. So I want to take a breath for myself and see any questions popped up.
We actually have a number of questions. One was that if you could, if there was a way to quickly repeat the statistics on the number of students who contemplate suicide. I think you did it out of 1,000 and out of 10,000.
Sure. So contemplate an attempt, I think.
Yeah, it says it specifically out of the 2,000 who contemplate suicide was the question.
Okay. So contemplation, I believe it was for out of 1,000 students, I think it's 14%, so around 140 students. And then 60 would plan an attempt, and about 14, now I'm questioning myself, but around that might actually make an attempt.
Another question was, what percentage of college student deaths from suicide are from blind or visually impaired students? That's a great question. I don't think we have data on that, unfortunately. Although unfortunately, I don't think we have data on that. One of the challenges actually in doing college student suicide prevention is we don't have data on the number of students who die by suicide because, again, those are hard to determine. When on like death certificates, they don't say if someone who died by suicide was a college student or not. So we can look at ages, but it's hard to really determine if a student was or if a person was a college student. And campuses, as you can imagine, don't really want to share that because they don't want the image of being like a suicide school or whatever. And they count them differently. So a lot of students die on breaks, or maybe we're enrolled and then this semester they're not enrolled, and then that's when they die by suicide. And so some campuses count those and some campuses don't. And so getting accurate data on college student deaths is actually really hard. And one more for now, and then I'll let you get back to the talk. Sure. How would you describe the difference between a public health approach and a behavioral health approach? Great question. When I think of public health, I think of involving lots of different people outside of the behavioral health field. So recognizing that we can all do things to increase just mental health and well-being, thinking about policies and procedures and how those impact health versus a behavioral health approach is very individually focused. So public health focuses on environment and culture and procedures and kind of things outside the individual versus behavioral health focuses on individuals and changing their thoughts and their behaviors and their reactions to things, how they manage their emotions. So that would be kind of the biggest difference. Great. That is all for now. Okay. Thank you. Sure. So the next strategy is effective care and treatment. It's kind of shocking to a lot of people that most mental health providers, this is slowly changing, but most mental health providers are not trained specifically in working with individuals at risk for suicide. So they're often trained in mental illness and how to treat mental illnesses. And suicide is not considered a mental illness. It's a behavior. It's might be a manifestation of a mental illness, but it's not its own mental illness. And so there's often kind of this idea of, okay, we get through the suicidal crisis. They're out of that. Now let's treat the depression. If we address the depression, then the suicide will go away. However, that doesn't really work that well. And a lot of people don't have depression. We're still suicidal. So we need to address the suicide specifically. And so it's only in like the past 20 years or so that we really have some evidence-based treatments for suicidal thoughts and behaviors. And so our office does a lot of work in trying to get campus mental health providers trained in those interventions, as well as our community mental health providers. We also provide training for our graduate students and clinical training programs, knowing they're going to go out into the field throughout the state and the country. And we want them trained and ready to respond appropriately to people at risk for suicide. And when those specific interventions are used, we have much greater success rates in preventing suicide. We also want to train our healthcare providers in how to respond. So they're not going to provide long-term therapy, but there are interventions that they can do that also reduce risk. So there's something called safety planning. which we can do in the emergency department or even just meeting with your primary care provider. And it's basically kind of identifying what are your warning signs and what are your triggers. Who are the people you can call? What are the things that you can do when you get in that moment of tunnel vision about having suicidal thoughts? What are your coping strategies that you can go to? So when people get suicidal, they get this tunnel vision and they kind of forget all their coping strategies to just go out the window. And so creating a safety plan that you keep on your phone or you keep in your wallet that you can like pull out and be like, oh yeah, I enjoy going on walking in nature. I'm gonna go try that before I think about ending my life. Maybe going to Walmart and just walking around because there's always people at Walmart. Getting kind of outside myself and unisolated, that might be helpful. My brother knows I struggle. I can call him and here's his number, or I can go to the ER, kind of just a list of strategies that somebody can do in response to suicidal thoughts. That's a very brief intervention that any provider can do. So we want to train them in those as well. And then we want to connect our campuses with community agencies offering multiple levels of care. So most campuses can't provide inpatient care, for example, and sometimes that's necessary. So we want to make sure that we have relationships with organizations or healthcare institutions that can provide that level of care so that we can seamlessly refer students over to them. And when we think about this at the community level, we want to identify, particularly for our rural or under-resourced communities, how can we get people in those communities, knowing especially our rural communities are at higher risk anyways, how can we get them access to care? So how can we set up telehealth? One of the blessings of COVID is we have much greater access to healthcare now because lots more people are doing telehealth. And so how can we make sure we can get psychiatrists to provide mental health services to our rural communities who don't have that? Where are we going to take our people in our rural community to get inpatient care if that's necessary? And how is that connection made? The next one is care transitions and linkages. So we know that when someone is discharged from the hospital after having a suicidal crisis, they are at enormously high levels of risk for the next week, month, few months. So just because they're discharged from the hospital does not mean that the suicidal thoughts have gone away. They're actually at still a much greater risk. And so we want to make sure that they follow up with long-term care, or at least longer-term care. And about 50% of people don't ever follow through with their outpatient appointment. So maybe an appointment's made for them and they never go to it, or sometimes they're just given a number to call and say, go make your appointment and go see someone, and they don't follow through with it. And so lots of people fall through the cracks. And so care transitions and linkages says we need to help those people manage those transitions and make sure they get linked to the care that they need. So for students, one of the care transitions that they have is they're transitioning to college. A lot of them go away to college. So they may have been seeing a mental health provider at home, but now they're 2 hours away from that person. They're not seeing them. And some students think, I'm going to try and go it alone and not see anyone. And that works for some, and for some that really doesn't work well at all. And so we want to make sure they're getting connected with a provider either on campus or in their campus community. And so proactively reaching out to students and saying, hey, we're here for you. We provide these services. If you'd like to meet with us to discuss transitioning care, we'd love to set up an appointment with you. Here's how to do that. Here's providers in our community you could reach out to. And being very proactive to help make those connections and making sure we're getting their records. So we're not treating them blindly. We know what's been going on with them, and so we know how best to support them. A lot of campuses are now starting to employ case managers. So they're especially helpful when a student has been discharged from the hospital or has been through a crisis and they're coming back to campus. They can make sure they follow through on their outpatient appointments. They can make sure that they are managing their academic work okay. So they're not being punished for having been in the hospital, but that their faculty knows to be supportive of them without disclosing too much information. They can provide support for a student in managing peer relationships, and when their roommates want to know kind of what happened, how to have those conversations, or kind of coaching them through that. And they can just kind of be that support for students. So case managers have been really effective for campuses. Then postvention. So we know people die by suicide. And we don't like to think about it until it happens. And that is the worst time to be trying to plan how to respond to that. And we know that when somebody dies for suicide, it puts other people in their social circle at greater risk. And so postvention is having practices in place about how to respond to that death in a way that supports everyone's grieving, but also keeps safety in mind and reduces risk for others. So we encourage campuses to plan ahead and to have a protocol for student deaths, for all deaths, not just death by suicide. But how are you going to respond? Who's going to notify parents? Who's going to notify their close friends? Are we going to notify close friends before we make a general campus announcement? What's going to be shared in that announcement? We know, especially for suicide, there are safe ways of talking about it and there are unsafe ways. So we want to make sure our public relations office knows kind of what those guidelines are and follows those guidelines and how they inform and what information is shared. We also want to offer support and resources to the friends and those affected by the death as quickly as possible. So that means we have to plan what those are, what's available to them. We want to provide for them ways to grieve, ways to celebrate that person's life that are safe, that honor the person who died, that are respectful of the person who died and their family, and that are safe for those who are affected, that don't kind of glorify the death by suicide, but still respect and honor the person and the life lost. And then life skills and resilience. So again, kind of thinking very upstream, if we can give people coping skills and resiliency skills, then hopefully they won't go down that river and start drowning in the river of suicide. So a lot of campuses do skill building workshops and programs that all students are invited to, promoting things like stress management, test anxiety, financial management. Again, if we can plan for how to manage your finances, then students won't experience that risk factor. And students are often managing finances for the first time in their life, so they have no idea what they're doing. If I asked, I'm sure many of you would report like you had credit card problems in college because you had no idea what you're doing with them. So hosting workshops for the general population, especially for those students who will never seek counseling, even though they might need it. We can host kind of just general educational programs for them to help them learn some basic emotional well-being type skills. And then we also work with campuses on just creating a culture that promotes personal well-being, caring for your neighbor, learning from your mistakes, showing grace to one another and grace to yourself, and personal growth. So this starts at the top. These messages need to come from our presidents and our vice presidents and our deans. And then those trickle down to faculty and staff who then continue to reinforce those messages in their classrooms and their day-to-day interactions with students. So often presidents send out general emails to the campus, kind of talking about a national event or just kind of what's going on, or encouraging them. Like right now, we're about to face exams are coming up. And it's a particularly stressful, hard time for students. And so a lot of presidents send out an email saying, hey, this is a hard time. Good luck on your exams. Study hard, but also take care of yourself. Don't forget to sleep. Don't forget to eat. Don't forget to get outside and see some sunshine once in a while, because those things are important too. Your mental health is important too. And grades are important, but it's not the end of the world. We need to prepare students who often don't have a lot of failure experiences at this time in their life. We need to help them understand that a failure of a class is not the end of the world. There's a path to recovery for that. And this is what it is. It's okay to learn from mistakes. We all make them. So just kind of creating a culture where that's expected and acknowledged and supported. Finally, connectedness and belongingness. So we know that lack of connectedness is a huge risk factor for suicide. Feeling like you're a burden to others is a big risk factor for suicide. And so finding ways for everyone to feel like they have connections to others. So we want campuses to have a wide variety of clubs and organizations and teams so that every student, no matter what their interests are, can find a place to plug in, connect with others who are similar to them or have similar interests, values, etc. And we want to provide opportunities for everyone to contribute. That might be serving their organization. That might be serving in the community. That might be serving on campus somehow. But everybody needs to find a way to make a meaningful contribution. So again, if you think about this at the community level, how are we integrating people in the community? how are we getting to know our neighbors and providing ways to contribute to one another? How are we getting people involved so that they feel like they're needed, they're valued, they're wanted, and they're not a burden, that they're connected to others? So those are the 9 strategies. Hopefully, I've given some examples that help you see how they apply both on a college campus as well as just the larger community. That no matter who you are, everybody has a role to play in suicide prevention. We can all work on our abilities to identify people, refer them to resources, encourage help seeking, just being connected to others, just saying like, hey, how's it going? I haven't seen you lately. Why don't you come with me to go for a walk? Or I could really use your help doing something around the house. Would you mind coming over and helping me out? So finding ways to acknowledge that suicide prevention is everybody's responsibility. It's not just the mental health field. So I guess that's it for my presentation. So I don't know if there's more questions. My contact information is up here. And I also encourage you to check out our website. We're constantly updating it with new resources. Most of them are relevant specifically to college students, but we do have some general resources as well. But with that, any questions?
So one that came up while you were talking before was from someone who works at a high school who asked, when they have a student commit suicide, is it better to acknowledge it and address the situation or keep it under wraps as much as possible and not bring attention to it? Sometimes it seems strange to staff and students when it's not acknowledged, was asked. What are your thoughts?
So my general thoughts are students know and students talk. And so I think acknowledge it, transparency is good. Again, there are guidelines about how to talk about it safely. So you don't want to focus a lot of attention on the method that they used to die or where they were. But you want to acknowledge that somebody lost their life and that there are resources that are available and that suicide is preventable, and that if anybody else is struggling, here are resources available. Here's some counselors that are available to talk to you, provide opportunities for them to acknowledge it and cope with it. So yeah, I always think transparency is the best policy.
Is there any statewide requirement or law for graduate students in counseling social work to have suicide prevention and intervention training or risk assessment?
Great question. I don't believe so currently. And I'm not sure I know of any state that says it has to be present in training. But I wouldn't quote me on that. But there are some states who require a certain number of continuing education credits related to suicide prevention every year. I don't believe Virginia has any of those laws in place, but a few states do.
Someone else asked about early on, what can people do to get more involved in suicide prevention? You had the whole conversation, but are there groups or things that people could be involved with? Sure.
So if you can find a gatekeeper training, I'd encourage you to attend one of those. They are offered in the community sometimes. Just to educate yourself about warning signs and how to intervene with someone. So good organizations to potentially look into are the American Foundation for Suicide Prevention. So they're very publicly oriented. They do walks and raise money for research and interventions. The Mental Health Association of America, I believe there's a Virginia chapter. Could look into that. Again, they do a lot of public programming. There are lots of local organizations too. There's several communities have suicide prevention coalitions that you could be a part of that do programming and interventions and focus on training and developing policies. So those would be my main suggestions.
And we've worked really closely with NAMI, which is the National Association of Mental Illness, the Virginia chapters, with our Mind Matters mental health exhibit. And I just dropped, they've been wonderful. And they definitely have opportunities for folks who are interested. And I dropped their link in the chat.
Thank you. Yes, NAMI is wonderful and does some great work as well.
Question, did you happen to know in the general population of the United States what the statistics are around suicide?
Right. So the first slides that I showed were kind of the general population. So again, 10th leading cause of death, and about 48,000 people died in a year. Suicide. Over 1 million have making a plan. Make an attempt. And like 15 million have serious thoughts of suicide.
Someone else, and I think this is our last question, is someone asked about, do campuses ever address things like food insecurity or homelessness as part of a comprehensive suicide prevention approach?
Absolutely. Yeah, great question. So case managers certainly help with that. So for campuses that have kind of taken a case manager approach, they're great at that. But yes, more and more of our campuses now have kind of pop-up pantries or have food pantries that students can access. I know at James Madison, they have one that any student can access anytime, just to go get kind of basic food needs. Housing insecurity, I would say there are some interventions being done. I'm honestly less familiar with some of that, and I don't think it's as consistent across campuses. So the food insecurity is certainly being recognized as a big issue among college students, and most campuses are addressing that now. Housing, it's certainly an area we need to address. I know our community colleges do a lot more work in that area because it's a very prevalent issue among our community college students. But I think there'd be a lot of just kind of connecting them with social services and finding some resources that are available to them there.
I really want to thank Dr. Gibbs. This was a very informative conversation. Thank you for everyone for joining us. Next week, we will be back at Wednesday at noon for a very different conversation. Building the Broaden roller coaster. So it'll be about the physics of roller coasters and roller coaster safety at Busch Gardens. So thank you, everybody. Have a good afternoon.